I would like to welcome you to the session Quo Vadis, Medicines and Universal Health Coverage. My name is Veronica Wirtz, and I'm the co-chair of the Medicines and Health System Thematic Working Group and the moderator of today's session. It is great to see so many colleagues and friends from around the globe connected today with us. The session is organized by the Medicines and Health System Thematic Working Group of Health System Global. We would like to thank the Symposium in Health Systems for including that session in the symposium program. Quo Vadis is a Latin expression and means, where are you marching? In the next hour or so, we would like to invite you onto a journey about the directions that countries and regions are taking to scale up medicines and universal health coverage. We would like to examine the challenges and the opportunities in doing so. For this, we have invited a panelist of experts with extensive experience in the field of medicines and health systems. Let me show you that here on the screen, who we have here on the panel with me today. So we have as speakers of today, Marie Lamy. She's the director of the Asia Pacific Leader Malaria Alliance. We have Rita Saikas, the consultant of the Center for Health Policy and Study in Moldova. We have Anaí Dresser, a researcher and professor at the National Institute of Public Health in Mexico, and Danaki Raghu, pharmacist from Kenya and a current student in the Doctor in Public Health program at Boston University School of Public Health. We would like to start and set the scene for you by highlighting the 6 challenges that the Lancet Commission on Universal Health Coverage and Access to Medicine has put forward as important to address when scaling up universal health coverage and access to medicines. We would like to address 4 of these key challenges that you see here displayed on the slide in our session today. Assuring quality and safety of essential medicines. Marie will talking about that. Making essential medicines affordable. Rita will address that. Promoting quality use in medicines. Anaí in her presentation will do so. And then the cross-cutting theme of measuring progress will be addressed by Sana at the end. We will have for each of the speakers around 10 minutes, and then we will open it up for a discussion section and session with our participants. And for that, we would like to invite you to submit your questions through the chat functions, and we will try to take as many as possible during the discussion section. I would like now to invite Marie Lamy to share with us her presentation. Thank you.
Thank you very much, Dr. Veronica. So if you just give me 1 second, I will kick us off by sharing my screen and the slides that I will follow for this presentation. So as Veronica mentioned, we will be speaking to a variety of different topics related to what was alluded to in the Lancet Commission on UHC and access to essential medicines. And the context that I would like to bring forward in just this opening presentation is with a geographic focus on Asia Pacific, speaking about access to quality antimalarials for malaria elimination, and specifically what we mean by equitable access to quality essential medicines. So just by way of introduction, my name is Marie. I'm a director of policy within the Asia Pacific Leaders Malaria Alliance, or APOLMA, and we are based in Singapore, and we work with 22 different countries in the Asia Pacific region to push the malaria elimination agenda forward. So just a bit of context on universal health coverage and what this means in the context of malaria for Asia Pacific in particular. Just for background, at the East Asia Summit in 2014, heads of state actually committed to the goal of eliminating malaria as an infectious disease from Asia and the Pacific by the year 2030. So that's 9 years from now. We also are all, I am sure, familiar with Sustainable Development Goal 3 and 3.8 in particular, which speaks to UHC, stipulating that all individuals and communities should receive the health services that they need without suffering financial hardship. So in the context of malaria, what does UHC mean? It really means access to subsidized bed nets for protection from mosquito bites for all populations at risk. It also means the availability of free malaria diagnostic tests to know what strain of malaria the patient has, if any, and also access to the right treatments at all point of care facilities, all the way down to the village level where most of malaria actually happens. So for context, as many of you might know as well, malaria is a disease of the rural poor. And in Asia Pacific specifically, although our region is fast approaching elimination, there are still over 300 million people at risk of malaria in the region. So in terms of when we speak about facilitating equitable access to antimalarials, it's really essential that key vulnerable populations, particularly mobile migrant populations, children and women in villages that are harder to reach, where there is less immediate access to health facilities, is absolutely critical if we are to achieve the goal of elimination. I just, on this slide, summarized a few of the core tenets of universal health coverage. The importance of prioritizing the poorest populations with the goal of really reducing health inequities in terms of access to health and particularly access to medicines. And also reducing as much as possible out-of-pocket spending. And that's part of avoiding suffering, financial suffering, basically. Increasing reliance, therefore, on public funding to cover those health costs for these populations, particularly for the poorer populations. And then developing the health system in general, and also access to health facilities and commodities for all the way to the last mile. And obviously, a lot of these core tenets are absolutely relevant when we think about COVID-19 and access to the diagnostics that we need, and also currently the COVID-19 vaccine, and making sure that it is accessible as well to the communities that need it, even in the more hard to reach vulnerable areas. So in terms of antimalarials and access to quality antimalarials for free, the great outcome of having an institution such as the Global Fund is that most of the antimalarial medicines that are available today are subsidized for all patients through the public sector and sometimes even through the private sector. So in terms of ensuring that all patients that all malaria patients have access to the right treatments, it's really about targeted distribution in the Asia Pacific region, and to ensure that we know where the areas where there are the highest burden are. Specifically, we need to rely on data, and this is where the importance of subnational data comes in, to ensure that we have really targeted intervention and targeted distribution of the available antimalarials without overusing stocks or leading to expiration of medicines. I also want to mention the role of community health workers, and basically, well, I will use the example of the Greater Mekong sub-region. We have a lot of the burden of malaria resides in villages that are often quite remote, in forested areas and hard to reach. And so the role of these community health workers has really been absolutely critical in terms of ensuring equitable access to diagnostic tests and the malaria medicines for these villages down to the last mile. In terms of improving quality access to quality antimalarials, I also wanted to mention the importance of a whole of government approach, where beyond just the public health sector, it's important to look at how we can improve health service delivery through private sector outlets where public health facilities may not be available, but also working through civil society organizations, and particularly as well the military, especially in cross-border areas where often the military are the only sector that actually operate, ensuring that armies are covered and that in those areas there is also adequate access to antimalarials. In terms of improving access to the subsidized quality medicines for malaria patients, there's a few examples from the region. I just wanted to mention Thailand's one and the social insurance card, which basically permits mobile migrant workers, even who are not residents of Thailand, but just come in for work in the forested areas, and allows them basically to access anti-malarial treatment at a subsidized price as well. Here I have adapted, this is a diagram that I included as part of my PhD in 2017, and it's an adaptation of a visual of access to medicines basically in a public health context and a health system context by Big Delhi et al., which was published in 2012. And I just wanted to highlight along this a few of the different drivers and constraints that we need to take into consideration when we look at access to medicines in a political context. One of those is economic drivers, very simply looking at the importance of access to antimalarials because of the economic impact of malaria itself, and how we need to ensure access to treatment to ensure that most of the populations at risk are able to continue their work and their economic activity. It's also one of the reasons why many of the forest workers, one of the at-risk populations, are most at risk of malaria because they work outdoors and are more exposed to the mosquito as the vectors of the disease, really out of economic necessity. And one point that we may get back to a little later is around transition financing plans and the fact that beyond global fund financing, especially in elimination settings, there's a question of how do we keep funding and subsidizing malaria treatments once external funding runs out. How and when do countries need to step in with their own domestic financing to ensure smooth procurement of these treatments? There's a few social cultural drivers that also affect access to medicines. I will not go into those into too much detail, as well as legal and regulatory constraints. One of those is having an adequate framework for the distribution of malaria commodities through private sector outlets where that is possible to increase basically the outreach and the accessibility of these commodities for patients at risk. But also from a regulatory standpoint, having the right approval processes within a regulatory authority to fast track the registration of a new antimalarial drug where it becomes available if there is a stated need in the country. And there's different mechanisms that exist in the Asia-Pacific region around that to facilitate the registration, for example, through the Australian-funded Regulatory Strengthening Program, or RSP. So why is it important to ensure continuous access to quality antimalarials? Because if there are gaps in the supply chain, many of us know that that creates opportunities for poor quality or substandard and falsified alternatives to reach patients. WHO actually estimated that up to 30% of essential medicines are potentially of poor quality in lower and middle income countries globally. Why is that dangerous? Because substandard falsified medicines don't contain the right amount of active ingredient, and so therefore can lead to either death from a disease, increased morbidity, or in the context of an elimination setting, simply reverse progress against these targets and really place a strain on the health system and the economy, as well as erode trust of patients in the public health system if this is a persistent problem. So how to solve this? Really, in addition to having ministries of health involved in the question, involving drug regulators and also law enforcement agencies in guaranteeing access to quality, affordable medicines, and making sure that poor quality alternatives don't make their way into the hands of the patients. So what does that mean next? Really, as a priority, what I really wanted to highlight, this is something that will come out in many different presentations tonight, is the importance of building strong health systems and importantly as well, responsive and well-funded regulatory authorities and regulatory systems and processes. What does this mean? It also requires political commitment and an increase in domestic financing to support the procurement and equitable access of affordable essential medicines, even once we move beyond external funding in certain countries. And then continued support and training for community health workers that have been so critical in testing and treating fever-related illnesses like malaria, but also COVID-19. And then finally, the option of pooled procurement and storage facilities, particularly in elimination settings where there may be a need for less stocks of certain commodities, and so ensuring that it is easier to quantify what is required from one country to the next and looking at it from a regional perspective. And finally, including antimalarials as part of existing health insurance schemes, so that once those medicines are no longer funded by the Global Fund, that they can be part of the subsidized list of essential medicines in that country as well. So I'll just like to stop here and pass the mic back to Veronica. And I would like to thank you for your attention and also look forward to your questions in the Q&A chat box on our platform. So thank you very much.
Thank you so much, Marie. This was a very, very nice start of the session. I would like now to ask Rita to continue the presentation, and just a quick comment to all our audience. Please send us your questions. I see already some people have started submitting questions in the chat. Please do so, and we will address them as many as possible after the presentation. So Rita, thank you.
Hello. So I would like to present the contribution of the non-government organization from Moldova involved in facilitating access and affordability to medicines. And data presented here are based on our involvement and operational researches held during the last years. So general overview on the local market, the country with the population of 4 billion and total health expenditure as a proportion of GDP is 7%. So out-of-pocket expenditure as a proportion of the current health expenditure is about 46. And if you want to speak about the pharmaceutical market, it is based on the imported medicines, about 45%, and generic medicines represent 82%. So we have 4 funding sources for medicine. The National Health Insurance Company funds medicines that are eligible for reimbursement at outpatient and inpatient level. Inpatient level means through the health facilities. The third contribution is Ministry of Health that support the national programs, including medicines for outpatient and inpatient level, especially inpatient level for TB and antiretroviral medicines. And also the government support 15 categories that are insured by the government, like children, pensioners, homeless. The third contribution is the private health expenditure, and the contribution out of pocket is 46%, where the major share represent out-of-pocket payment for medicines, 73.5%. And the first one source is international donors who are supporting TB and HIV programs, but we are going we are entering in transition period, and we already started to support and to share funding for medicines from the government budget. So despite of a lot of progress there, the key challenges are out-of-pocket expenditure for medicines are increasing. And in 2016, it was about 73.5 compared to 2008 when it was 64.4. These data were presented by the National Bureau of Statistics, but the same data we obtained through our operational researches in 2018. share of public expenditure for medicines of the total expenditure for medicines was 65.6 in 2015. Was less than was 6% compared to the 65 average level for the European Union countries. The population expenditure for medicine dispensed through the community pharmacy was 36% versus to 16% recorded in the countries of European Union. So how non-government organization can impact access to medicines? We know that access to medicines and affordability requires involvement of multi-sectoral involvement and multi-stakeholders involvement. And we as a non-government organization contribute through policy advocacy, evaluation, study, capacity buildings. And I'm going to refer to the recent operational researches from 2015, 18, and 19, and we analyzed different perspectives. Regulation, how to introduce medicines to be reimbursed. The regulation framework, how to introduce medicines in the essential medicines list. And also we try to identify a potential solution for improving access and affordability. So we, as a methodology, we did an assessment of the national regulator for 2 groups of medicines. And we did qualitative research of opinions and perception of the beneficiary, as well as actors of the system. And we did focus group interview, and this qualitative research was twice done in 15 and 18. As well, we assessed the alignment of the national essential medicines list to WHO essential list, and how the essential medicines list are reflected in the list of centralized public procurement of medicines. And the progress is up to date. We noted that the list of reimbursement medicines evolved from 5 INN in 2005, reaching 172 INN in 15 years. So the proportion of the budget for reimbursement medicines from the basic fund of the insurance company reached from 0.7% to 7.7%. So we see progresses for reimbursement medicines. As for the essential medicines, when we assessed the public tenders, we found the essential medicines list by INN was represented at the level of 51.6% in 2017 from the total list announced in the tender, centralized tender. When we look at the budget level was 65% for the essential medicines from the total budget contracted through the public tenders. So there are improvements, but still there is room. So another fundings, we found that only 62% of medicine that are reimbursed represents essential medicines. When we check the essential medicines list national that was approved, endorsed in 2011, the last one, with the recent list of the WHO, we found only 371 common INN. So the problem is with the revision of the list as per established schedule. Another barrier for access to essential medicines represent the regulation about pricing, and we have the requirements to have a registered manufacturer price in the national catalog, and we found only 42% of them have the price, which means if the price is not registered, they are not allowed for import. Even there are some specific conditions, but in general, this is a challenge. We assess the regulations through 4 criteria: transparency, relevance, revisability, and enforcement. And when we look at the transparency, we found gaps in regulation regarding taking a decision in a coherent and justified way. Regarding the processing of the dossier, regarding availability of reports, communication, involvement of expert team with specific skills related to health technology assessment. Regarding the relevance, we found lack of capacity and methodologies to define the strategic priorities for reimbursement and assessment of the evidences. Even the referent data or sources are mentioned in the regulations. Evidences for decision is not in all cases solid, and lack of technical tools and standards how to use health technology assessment elements. Revisability, so regarding this criteria, the regulation does not require to track new evidences or publications with the aim to further collect data about the medicines that are already included in the list of reimbursement medicines. And about the reinforcement of the regulations, there is lack of comprehensive list of indicators to measure impact of regulation. When we check the opinion of the population, I would like just to mention few data. So we found that 39 respondents that were non-beneficiary of medicines had the disease that was covered by the reimbursement list: hypertension, other cardio disease, chronic respiratory disease. When we ask, why did you decide to buy medicines in addition to the reimbursement ones, the answer was 50% was that the medicines was not part of the list of reimbursed medicines or doctor prescribed, and was 30% replied that medicines that are in the reimbursement list is less efficient. Another data pointed out that about distribution of beneficiary of reimbursement medicines according to the proportion of reimbursed medicine in the treatment schemes, and only 16% of patients had the treatment scheme fully reimbursed, and the 33% had the reimbursement, only 50% of medicines from the treatment scheme, from the all prescribed medicines. Another perception of the actors about patients, they told that the information is still insufficient despite of the improvement of the regulations, and they are still applying copying strategy for payment. But the doctors told that diversification of the list is in place. The financial threshold per institution was removed. Children groups are covered up to 18 years. Private sector told, or their perception is lack of transparency in decision making, in determination of the priorities, and lack of tools. So further contribution from a non-government organization was support to develop outpatient essential medicines list, drafted the regulation on the Commission for Selection Essential Medicines, and the list of indicators that covers policy, accessibility, affordability, and rational use. These components were done in 2019. So we have substantial steps for improvement of the mechanism regulation, but further efforts we need in order to have long-lasting changes in the area that we assessed during our operational research, meaning transparency, relevance of the decision, revisability, and implementations. Thank you. This information I wanted to share with you.
Thank you so much, Rita. This was very, very interesting, exciting, and also new developments. I think we will touch on several of the topics that you discussed in your presentation, because they are cross-cutting, not applying only to, not applicable only to Moldova, but to many other countries. So very exciting. Thank you so much, Rita, for the fantastic presentation. I would again invite the audience to submit questions in their chat. We are looking forward to a very engaging discussion after the presentation. So I will ask Anaï to go forward with her presentation. Thank you.
Thank you very much, Veronica, for inviting me, and thank you for all the participants to be in this session. Would you please confirm, Veronica, that you can see my screen?
Yes, please go ahead, Anaï. That's fantastic.
Okay, excellent. Okay, so I will be speaking in a few minutes about this dilemma between promoting access to medicines and at the same time attaining quality use of medicines. And I want to draw your attention to this statement from the Lancet Commission on Essential Medicines for Universal Health Coverage. that says that as universal health coverage enables more people to have access to medicines, problems with the use of medicines threaten to undermine the potential benefits by harming individuals, reducing the efficacy of medicines in the case of antimicrobial resistance, and also jeopardizing the financial stability of health systems. So this is something that several colleagues around the world have been pointing to, but it's still a big challenge in Mexico. I want to share some contextual information about Mexico. We have this is a very fragmented health system. And we have these social security institutions, long-standing social security institutions that are for formal sector employees and families and their families. Then we have from 2003, sorry, we have a new insurance scheme called Seguro Popular that was directed to the informal sector workers. But then parallel to this, we have this private sector, a large private sector in Mexico that is used not only with people without Social Security, but also people with Social Security and the people that have Seguro Popular, this new insurance system. And it's the utilization of the private sector is increasing and increasing. Of 40% of all outpatient visits are in the private sector. And something important is that most medicine expenditures in Mexico are out-of-pocket expenditures. And these medicines are the most significant component of health expenditure, especially for low-income households. So we have these three parallel systems going on. So what happened with Seguro Popular? Seguro Popular aimed to increase access to medicines by having many changes around the health system. One of them was the selection of medicines. We have Seguro Popular had a list of essential health interventions with the respective medicines for ambulatory care, but also a list for high-cost intervention with the respective treatment protocols. There was also improvements in the healthcare and supply systems, pricing and reimbursement, and financing. But the diverse evaluations about the impact of these reforms, Seguro Popular and expenditures in medicines, they found that definitely there was decreased catastrophic expenditures in health overall without in medicines, but very little, if any, effect on the out-of-pocket expenditures in medicines. For example, people won't spend as much medicines if they have a catastrophic situation like cancer, but in the day-by-day illnesses, they will still have out-of-pocket expenditures in medicines, buying them in the private sector. Why? Because there was not enough supply of medicines in the point of care, and there was also dissatisfaction with the public services offered. And so there's a significant use of the private providers. Something important is that all these reforms of Seguro Popular were not accompanied by an information system to track medicines utilization and expenditure. So most information that we have is from different kind of surveys. So we have different, as I mentioned, different private sector facilities, and one of them is the pharmacies. You can see one of these pictures is pharmacy clinics that are attached or just beside the pharmacy. So this is the pharmacy, and just behind it or within it there is a doctor's office. These pharmacy clinics boosted after the regulation of antibiotic sales only with medical prescription in 2010. We had this reform aiming to contain antimicrobial resistance that only, firstly, you can have over-the-counter antibiotics, but with this regulation, you had to have the medical prescription. So what the pharmacies did was just to hire doctors inside the pharmacy. And then, well, this was a boom in Mexico, and now over 7 of all ambulatory consultations in ambulatory consultations are in these pharmacy clinics. So it's not only for minor ailments, but even pregnant women, hypertension, many people are seeking care here. And users, most of them are for acute health problems, and most of them are for upper tract respiratory infections. But something interesting is that most users are affiliated to other health insurance systems. It's not only people without health insurance, it's people with health insurance, even Seguro Popular. They go to these pharmacy clinics. Why they go there if they have, you know, this Social Security or Seguro Popular insurance? Because of the low cost. It's really very cheap. It's $1 or $2 the consultation here. The proximity, they are really all over, especially in cities, and a short waiting time. So you can just walk in, and it will be a long opening hours, and it's very easy to use. And contrast, public services have long waiting times, and people will complain about mistreatment and lack of medicines provision. So even though they have coverage, they will go to these private sector services. But what is happening? So definitely these clinics are improving access to healthcare, and they're improving access to medicines. But there is a problem with the quality use of medicines, or the quality of prescription in these clinics. So what we found in a study from a large survey in Mexico is that even though patients in these pharmacy clinics where you have minor ailments such as upper tract respiratory infections, most of them were prescribed 3 or more medicines, and this is substantially more when we compare pharmacy clinics to other private clinics, Social Security or Ministry of Health, Seguro Popular clinics. So definitely there's something about driving overprescription in these clinics. And then we conducted a study about which medicines were prescribed, and we found that 80% of all patients seeking care for sore throat were prescribed antibiotics. This is much more that is needed. And even for those with Streptococcus pharyngitis, in the case they needed antibiotics, we found that only 5% of those were prescribed the antibiotic of choice, which is penicillin, but most of them were prescribed antibiotics not recommended. For example, third-generation cephalosporin, ceftriaxone, for example, is more for hospital use, but they are overprescribed in these clinics. So definitely a problem with the quality use of medicines. And so this is in the private sector, but what is happening in the public sector? And it's not much different. And this is a study of some of my colleagues that they use a satisfaction survey of Seguro Popular users, and they use this indicator for quality use of antibiotics from NHS in the UK. And that is the use of this group of antibiotics, broad spectrum antibiotics, as the total of prescribed antibiotics. And they found that in Mexico, it is 21% of all prescribed antibiotics are these broad spectrum antibiotics, whereas in the UK it's only 11%, and they want to meet the target of 10%. So definitely using just this indicator from the UK, we found that there is huge problem even in the public sector in Mexico. And what happened with COVID-19, where definitely this shed more light on the problems of quality use of medicines, both in the private and the public sector. Here we have competing treatment guidelines. Some of them recommending just paracetamol, others recommending ivermectin, even government clinics offering these COVID kits with ivermectin, azithromycin, and even pharmacies are also places where people with COVID-19 are seeking care. So definitely we have to pay attention to what's going on in the private sector as well. This is my last slide. Definitely in Mexico, efforts to expand coverage to attain universal health coverage has not been related to efforts to improve the quality use of medicines, and not been related to the private sector. And pharmacy clinics, overprescription happens, and lack of adherence to treatment guidelines, which might derive from a conflict of interest when we link prescribing and dispensing. However, we know that there are also problems with the quality use of medicines in the public sector. But maybe the most important problem is that we don't know the extension of these problems because we don't have a way to measure that. So now Seguro Popular in Mexico, it's over, and we're in a new reform. And they also want to attain universal health coverage. And definitely these efforts might benefit from information system to track medicines utilization, expenditures, and quality of use. And we definitely need routine monitoring indicators for access and use. And these efforts to improve access to healthcare medicines should be related to policies directed to improve use of medicines and antimicrobial stewardship, of course, and have to use a health systems perspective to engage different actors and subsystems. And that's everything. Very much. Thank you very much for your attention, and I look forward for your questions.
Thank you so much, Anai. This was a very, very interesting presentation about the engagement of the private sector and ensuring quality access in the private sector, a topic that is incredibly relevant. And thank you also for relating that to the COVID-19 pandemic. And I hope that we will receive also questions from you, the audience, related to these current challenges. I would like to hand it over now to Zana, who will close this part of the session today on presenting progress on universal health coverage and access to medicines. Zana, thank you so much.
Thank you very much, Veronica. I will just share my screen. It's a pleasure to be with you all today. I will be speaking about measuring progress towards UHC, and I will use Kenya as an example, specifically looking at how we can track equitable access to non-communicable disease medicines. So starting off with some context, just to give you a high-level summary of the Kenya health system, which is by no means comprehensive. There's a lot more nuance to the landscape. Kenya does have a devolved government, and at the national level, the health function is charged with setting the health agenda and developing the health policies as well. In addition, they provide technical assistance and capacity building for county governments. At the county level, the county government is responsible for implementing the Kenya health policy, as well as providing service delivery at primary and secondary health facilities in the county. Looking at efforts towards UHC in Kenya, the UHC landscape has been transforming rapidly over the last couple of years, and this slide highlights a few key actors involved in that process. At the national level, the Kenya government has committed to achieving UHC by 2022. And to this end, they launched the national UHC scheme, Afya Care, and this was launched as a pilot in 4 counties, which has since been scaled up to remaining counties through the signing of county-specific intergovernmental participatory agreements. So Afya Care, it built on the existing government provision for free primary health care and provided for free service delivery at public hospitals, which is level 4 and level 5 health facilities. And it also was designed to cover a range of services, including preventive, curative, and rehabilitative services, as well as free diagnostic services for minor ailments and free medicines. At the county level, the counties signed these county-specific IPAs with the national government. And counties are also able to establish their own initiatives to secure access to care for their residents, as we have seen with Makueni County, where they have Makueni Care, which I will mention again in a couple of slides. And it's also important to mention 2 other key actors when we're speaking about UHC in Kenya. There's the National Hospital Insurance Fund, NHIF, which is the parastatal mandated to provide health insurance for all Kenyans, and the Kenya Medical Supplies Authority, KEMSA, that's the parastatal mandated to supply essential medicines and commodities to counties, and therefore is a crucial player in ensuring uninterrupted supply chain of quality, affordable medicines for UHC. So shifting gears now to the case study that I'm going to use to describe how we can measure progress towards UHC. This is work that I undertook with my colleagues at Boston University and Innovations for Poverty Action Kenya, where we explored the trends across time on access to medicines at the household level in Kenya. And we were looking specifically with the expansion of 2 county-level UHC schemes, that is Afya Care, the national UHC scheme pilot in Nyeri County, and Makueni Care in Makueni County. So why NCDs? The burden of NCDs in Kenya is on the rise. NCDs are responsible for half of hospital admissions and almost 1/3 of all deaths. And access to NCD medicines has been identified as a major bottleneck, specifically availability and affordability of medicines. So with availability, some issues that arise include frequent stockouts at public health facilities. And as far as affordability goes, patients are not able to pay out of pocket for these chronic medications. Novartis Access emerged as a low-cost medicine program in 2016 that targeted 15 medicines for 4 NCDs, and Boston University was engaged as an independent evaluator of this program. And the study was undertaken in the 8 counties that are shaded on the map over here. So this is a study timeline for the Novartis Access evaluation, which I should mention is not the focus of this presentation. Rather, we use the Novartis Access data for this analysis on measuring progress towards UHC, specifically the phone surveillance data. So a random sample of households from the Novartis Access study at baseline was selected for phone surveillance, and they were called on a monthly basis between December 2016 and September 2019. And they were asked about the NCD medicines that they had at home, how much they paid for them, and where they got them. And just circling back to the UHC schemes of interest in this study, 2 of our study counties alongside this phone surveillance period of Novartis Access had UHC schemes emerge. So AfyaCare, which is the national government initiative that I mentioned earlier, was piloted in 4 counties from December 2018 to March 2020, and Nyeri County, which was a pilot county for AfyaCare, was also a Novartis Access study county. And in Makueni, another of the Novartis Access study counties, the government launched Makueni Care in October 2016. So both of these schemes still provide for free service delivery at public hospitals. And we sought out to use the phone surveillance data from Novartis Access evaluation to describe the trends across time and to estimate the impact of these UHC schemes on access to NCD medicines at the household. And this is tying together the Novartis Access study timeline with the launch of the UHC schemes. As you can see, Makueni Care launched right before phone surveillance started over here, and Nyeri and AfyaCare in Nyeri launched during phone surveillance. That we had 612 respondents contributing to this analysis, and we defined UHC as a binary variable based on the county of residence and the time of the launch of the UHC scheme. We also had 3 UHC groups emerge where Makueni County was always UHC. The Makueni Care launched before phone surveillance started. And then the switch to UHC group was Nyeri County, where AfyaCare launched during phone surveillance. The remaining 6 study counties were classified as never UHC because they did not have either of these UHC schemes of focus. And the outcomes of interest for us were availability of NCD medicines at the household, the place where they obtained their NCD medicines, and the proportion of NCD medicines that they obtained for free. So I'm just going to run through some key findings from this work. The first is that private chemists emerged as the most popular place of obtaining NCD medicines, as you can see here in red. And though that trend did decrease across time with the increasing obtainment of NCD medicines in public hospitals in green, throughout the study period, it's still evident that the private sector is accounting for a substantial amount of NCD medicines obtained. Another key finding here was looking at the proportion of free NCD medicines across time. As you can see, Makueni County in the always UHC group did have the highest proportion of free NCD medicines. And interesting to note there, in the switch to UHC group, after the launch of AfyaCare, we are seeing an increase in the trend of free NCD medicines. Looking at the impact analysis, we did run regression models adjusting for demographic variables, NCD diagnosis, time, and county of residence. And as you can see here, focused on the adjusted effects, we saw an increased odds of obtaining free NCD medicines with UHC. And we also did see that this did not have any impact on availability of NCD medicines in the household. So tying this all together, some key takeaways are that, well, first thing is the private chemists did emerge as a significant player in the supply of NCD medicines. And this is important to note because patients will be paying out of pocket for medicines in this sector. And it highlights the relevance of the private sector in Kenya's steps to roll out UHC moving forward. We also saw that UHC did result in an increased odds of obtaining NCD medicines for free. And this highlights that the UHC schemes are in fact playing a role in facilitating financial risk protection, one of the core goals of achieving UHC. However, we did not see an impact on availability of NCD medicines at the household, even though the medicines were clearly more affordable, with people obtaining more medicines for free. And this highlights the multifaceted nature of access to medicines, which my colleagues have touched on, where we are seeing that addressing affordability is not the only component we need to be thinking about when we are making efforts to increase access to NCD medicines and to medicines in general. Which brings me to my last point. A key lesson here is, as we are thinking about subsidizing costs of medicines, we also need to ensure that this is aligned with supply side investments, such that we are ensuring availability of quality medicines in the public health facilities. Thank you very much for your time, and thank you to my colleagues, without which this work would not have been possible. I'll hand over to you, Veronica. Veronica, you're muted, sorry.
Yes, thank you so much, Zana. Thank you for your presentation. With this, we conclude the part of the presentation. I would like to ask all the presenters to switch on their camera. We will now have a panel discussion. We have received already one question in the chat. I would like to encourage and invite all our audience from around the world to engage with us in the coming half an hour or so, 45 minutes, half an hour, 25 minutes in that discussion and tying this all together. And I think we had a very a nice collection of different experiences in scaling up universal health coverage and access to medicines. And we spoke about different challenges, key challenges. We spoke about quality, ensuring quality of medicines. Marie spoke about it. We spoke about the expansion of the benefit package. Rita went into detail what the role of an NGO could be in examining that and studying that, what the role of government and the institutions are. Anais spoke about the ensuring quality use of medicines and how important that is when you expand availability of medicines. And Lana did a very nice presentation at the end to illustrate how important it is to measure progress. So I would like to pick it off, or to start our discussion with Marie, and with a question that we received about her presentation, which is incredibly important. Now, Marie, you talked about the whole government approach. And the question is exactly about how we can ensure a whole government approach, particularly when we think about the private sector. So the question is, how can we assess the effectiveness of engagement of the private sector, and that they are serving the public good? That speaks very much about some of the potential conflicts and frictions that can come about when involving the private sector. So Marie, I'll let you speak about that.
Thank you, and I would like to also thank our participant, Hoda Khaled Hassan, for submitting that question. And so just in short, would like to sort of offer my perspective on how we see it done in the Asia Pacific region. So there's two components, I guess. The first is having a framework in place under which, for these essential medicines that are absolutely critical to the malaria response and to the elimination targets, that there's a framework through which they can be distributed in the public health sector and in the private health sector, so that the private health sector service delivery outlets are able to follow the same rules and guidelines in terms of issuing these medicines after being able to test the patients and confirming the diagnosis, and that they follow the exact same process within that framework. So actually having a legal framework in place. It speaks to that diagram I shared around access to medicines and the importance of legal and regulatory enablers and constraints, having those in place basically to make sure things work well. And then the second part is making sure that the distribution of medicines through private sector outlets isn't done sort of as a completely separate endeavor, and that it's part of the same reporting system. So really ensuring that every case that is detected in the private sector is then reported back into the same data system that is either owned by the National Malaria Control Program or other, and that there's that visibility in terms of cases and basically stocks of ACTs, anti-malarial combination therapies, artemisinin combination therapies or antimalarials distributed to the patient. So the framework, the legal framework or the policy framework, and then the reporting system would be two ways to ensure that we can assess effectiveness and accountability. Thank you.
Thank you very much, Marie. Exactly, you hit on very important points in terms of ensuring effectiveness, and particularly I would like to highlight the point of data, having data available to monitor the actions and the services and the service provision in the private sector. I wonder, Anaï, if you have anything to add, because that touches very much upon what you have presented, and also the difficulty of assessing what services are provided in the private sector and whether these services are really adhering to a certain quality standard.
Thank you very much, Veronica. And I completely agree with what Marie has pointed to. It definitely is a two-sided coin, and you just can't focus on one side without paying attention to the other side, of course. So the drivers of utilization in the public sector and in the private sector are one related to the other. So these universal health coverage reforms have to integrate the private sector, definitely. And one way to do that is to build these governance systems with specific indicators on the access to medicines and the utilization of medicines and quality use of that, with the same set of indicators for the public sector and the private sector, and making them visible, and this system of transparency and accountability. So it's obvious that keep tracking of those indicators. I think that will be a very good beginning for any system, just to define, as my colleague Rita did in that initiative in Moldova, we're having these key indicators. I think it's very important, but just being sure to have the same ones for the private and the public sector and make that transparent for everybody.
Thank you, Anaï. And with this, I would like to hand it over to Rita. Rita, you spoke about indicators and the importance of indicators, not only in this sense, as Marie and Anaï alluded to, to measuring whether services deliver to a certain quality standard, but you mentioned quality indicators in the sense also of how we make the indicators, the importance of indicators, and how do we measure progress towards the benefit package. And I wonder if you can mention some of these indicators that have been used in Moldova, or that are proposed to be used in Moldova, and particularly the topic of transparency around it. So for instance, how is data then made available to show what is measured? So Rita, I let you talk a bit more about, expand a bit more on the topic of indicators and transparency.
Thank you to everybody. About indicators, indeed, it's offer the possibility to measure all the policy develop if the policies are working properly. And we try to develop, we are at the stage of discussion with the government. We developed and we presented them, and we are discussing with them to embed them in the regulation at each level, because the indicators follow the pathway of the medicine, starting from the registration up to the through procurement up to the rational use of medicines. And as we I mentioned, this sector is involves multi-sectoral sectors. We discussed with the Minister of Health, with the accreditation department, with the licensing chamber, with the insurance company. And for instance, let's say, in order to improve transparency and decrease out-of-pocket payment, I mean, we one of the indicators at the level of the registration, we try to understand how the percentage of essential medicine that have registered less than 3 INN in the national register, which means if you follow these indicators, we may mitigate the risk about the lack of available product on the market, or lack of the competition, or to identify alternative solution in order to be approved by the Minister of Health in such situation. Or the percentage of medicines for palliative care, exception injectable forms that are present in the community pharmacy and in the hospital pharmacy, in order to push prescription of solid form, I mean tablets, and to decrease the burden of the injectable formulation for palliative care. Another indicators for economical measurement is index of economical accessibility of medicines, and this indicator is already embedded in the regulation for reimbursement medicines, but the problem is they didn't develop the methodology. Sometimes developing country copying the regulation, good regulations that are in developed countries, but they are not adjusted, and they are not supported with the methodology, tools, and even capacity building to apply properly these indicators. Also, we looked at, let's say, at the rational use of medicines, if the list is updated on time, because we need to have a coherence approach, holistic approach, in order to achieve the results. If the list is delayed in revision, we do not have proper care of services. If I mean, if we are not keeping the pathway with the WHO essential list, let's say, that's why one of the indicators looks like if the list was updated every 2 years, let's say, if the list is present in the at each level, then when the licensing chamber visits an inspection, visits the pharmacy, they should count the physical accessibility of the medicines, and there is indicators about the presence at the moment of the visit of the essential medicines with the formula for calculations. I mean, we approached all components of medicines movement in the market regarding the monitoring, presence, and rational use, and the budget.
Thank you so much, Rita. This was very useful. I think also the nuance that you gave to the example in saying, yes, we have indicators, but some of these indicator methodology needs to be adapted to our system, to our capacities, to our human resources, etc. So an extremely important aspect, which sometimes we forget, we say very easily, oh, this is an indicator, use that indicator, without thinking much through what this means for a system. It means the organizations, that means data systems available, that means the human resource capacity, etc. So it has obviously a system implication, which often we don't examine. Rita.
And also, I wanted to add that about transparency. Transparency not about the policy, but also about operational level. We developed a set of indicators for the insurance company to be able to monitor their decisions, their functionality as the commission, their criteria, by asking the timeline to be monitored for assessing dossier, for publication of the reports, and the implementation of the minutes. I mean, two directions, like the policy and the technological level, like operational level.
Mm-hmm. Very important. Thank you very much, Rita. And now we would also like to give the word to Sana for perhaps continuing our thread of the discussion around measurement and how important is measurement. You talked about universal health coverage and the rollout in different counties at different paces. No? Some counties using a pilot, some other counties using their own insurance scheme, and how are counties routinely measuring progress towards affordability? You used obviously data that was available and originally used for another study to do so, but I wonder, how is this routinely done? Is it even feasible? What do you see as feasible steps to measure progress towards universal health coverage, particularly things like affordability that you identified as critical?
Thanks, Veronica. That's a great question, and not the easiest to answer. I would say that there's no apparent system in place based on what's the information that's available in the public domain, with how counties are routinely, whether they have an actual data management system or a way of reaching households to measure affordability of medicines. And I would say that that situation is different if we consider the health facility, where we do have the district health information system, which the county governments could use to measure the utilization of health services in the facility and the use of medicines as well to track progress. So looking at Makueni, for example, I know that the first 3 years of Makueni Care, and Makueni has done amazing work with their health insurance scheme and mobilizing their residents to register into this scheme. However, the first 3 years of Makueni Care registration onto the scheme was manual, and once you register for a year, and households are required to pay 500 shillings or $5 for a year, you're not automatically registered in the following year. You would need to re-register. And so it wasn't until 2019 that they started digitizing the process of registering onto this scheme. So I think that which made it very difficult to track which households, whether people were staying on or whether it was new households registering each year. But with this digitization of the registration process, I think we are making a step towards being able to see who is on this scheme, and then what is the benefit of them being on this scheme? Are the medicines more affordable and such? So I think that digitization and having data systems in place to be able to track the people on this scheme is a first big step. I also think that Kenya has recently launched the Kenya Community Health Policy, where there's a big push to increase the capacity of primary healthcare, and I think leveraging community health volunteers and community health workers to the end of reaching households would be another useful step for counties to take. Additionally, mobile phone ownership in Kenya is really high. Mobile phone penetration is above 100% now, according to the Communications Authority of Kenya, and that's because people can own more than one SIM card. So using the mobile phone technology like we saw with Novartis, while the data was not intended for measuring UHC progress, it served a very useful purpose in that regard. I do think that having a register of patients with their contacts, of households and residents of counties with their contacts, and being able to follow up with them on the benefits that they're accruing from registration into the UHC scheme would be a good way forward.
Thank you so much, Sana. This is excellent, and I think a nice wrap up to the theme of measurement and how important that is. I would like to come back to one of the important topics, Marie, that you alluded to in your presentation, which applies to many countries around the world and has to do with the rollout of universal health coverage, but also the donor transition. You spoke about the transition of many countries from donor support towards more domestic resources. You, at the same time, you spoke about the important supply that countries receive through donor support, particularly for anti-malaria medication. And I was wondering if you can comment, what do you foresee as the impact moving from donor-supported supply of medicines towards more domestic reliance of procurement to medicines in regards to quality of medicines?
Thank you, Veronica, for this question. I mean, there's no denying that having a funding body like the Global Fund, has allowed basically to flood the market with these essential medicines for the three main diseases that are malaria, HIV/AIDS, and tuberculosis, and really helping move the needle. It's also understandable given shifting priorities that some countries that are moving towards middle income status and for which the burden of certain of these diseases is slowly reducing, that they are asked to take more responsibility. And wherever possible, where there's room for them to invest some of their own sort of revenues into health, that is a prompt for them to do so. So in terms of transitioning away from external funding, so to speak, there's a few risks. One is that there are gaps essentially in the procurement and supply of some of these essential commodities. And so one key factor is really planning ahead, and what we're doing, not us exclusively as Appelma, but as a community of stakeholders working on malaria, is making sure that conversation happens early on, and ensure that we basically flag this upcoming potential issue and say, this is something that we need to take into consideration. Let's encourage countries to set up financing sustainability plans for this transition, where in those plans there is a component around ensuring the continued procurement, the adequate quantification, the supply and distribution of all of the essential commodities that will be required to then continue the malaria response in that case. So that's one thing as an organization around policy advocacy that we try to encourage, and then we do so by sharing examples from countries that have a financing sustainability plan in place, and also link the country stakeholders with the partners that might be able to help them develop this plan that is adapted to their own context. So really taking that into consideration early on to ensure that there is no gap. Any gap in the supply of these medicines could reverse progress by many years. So I think that's quite critical to highlight. And you're muted.
Thank you, Marie, for that explanation and also your assessment of that situation and the importance of moving forward. I would like to give everyone an opportunity to say very briefly a last, let's say, closing remarks, and I would like to start with Anna.
Sure, thank you so much, Veronica, and to my fellow panelists. This has been such a great learning opportunity and great to hear about the experiences from your various countries. My key takeaway from today is thinking about the prominent role that the private chemists and private sector play in Kenya, as we saw from my example, and how many people do obtain their NCD medicines from this sector. And moving forwards, as we make steps towards UHC, how we can learn from the experiences of other countries, as Anahi talked through the experience and the challenges with regulating the private chemists and private sector in Mexico, and the quality issues that may arise with engaging the private sector. So I look forward to seeing how Kenya proceeds in attempting to regulate and loop in the private sector in efforts towards UHC. Thanks all.
Thank you, Zana. Anna.
Thank you very much, Veronica and colleagues. It was an excellent seminar, and I agree with Sana. I think the best thing we can do to move forward is to learn from each other, different countries learning from their own experience, the good experiences and the not good experiences, and that's definitely a way to learn. And I just want to close with two remarks. One of them is about human resources for planning and for achieving a good management and planning of medicines in the health sectors. It's something that is not easy to do, and you need specific knowledge to do so. And it's not only, in this reform we have it in Mexico is we have this reform that is changing how medicines are bought, or how medicines are transport to different points, but you need planning, and you have to track which medicines you will need for which conditions, and are you going to measure how they are used or not. So for that you need trained people and lots of capacity in human resources. So this is in this connection of health system, this building block of medicine has to be connected with this other building block about human resources and having, of course, information systems. So I think that connection has to be strengthened in all countries, definitely, and in Mexico. And the other remark I want to do is the lessons we have with COVID-19 and other large emergencies that we surely will face in the future. That is, of course, we have to have this quick response of and how to adapt quickly the health systems to respond to these. Any emergencies can be, an earthquake from a pandemic, and how to have access to medicines related to that emergency, but also quality use, how to integrate systems to assure quality use of medicines within the emergency. I think that's something that we have to be working in the near future for future emergencies. Thank you very much.
Thank you, Anai. We have 30 seconds left. I would like to thank the audience before the session closes for the wonderful journey throughout the regions and the countries of the world on access to medicines. I really hope that you accompany us in the thematic working group of Health Systems Global, further on medicines and health systems, the audience and the panelists for a fantastic session. So I hope I will be in touch with all of you very soon.